My name is Brandon Ayers. I'm from down in Philadelphia, part of the cornea service at Wills Eye Hospital. And down there, we serve a role as an anterior segment surgeon, cornea transplant specialist, and we do cataract surgery as well. But most of my cataract surgery is referred in. But every once in a while, somebody will send their mom or dad, or they come from a normal source, and I get to do regular cataract surgery, or so I think. Now, I'd like to make a couple disclosures. My first disclosure is that I'm not as smart as these guys, and I need their help to figure out how these cases are going to work out. So I'm real excited. I've got a patient coming in. This is a normal patient, 70-year-old man, complains of plain old reduced vision. He's told he's got a cataract, worse in his right eye versus his left. His vision, 20/70 in the right eye, 20/25 in the left, doesn't have too many complaints on that left side. In his glasses, he's got about 2.5, maybe 3 diopters of astigmatism, not quite so much in the left eye. And over the past couple of months, we've seen a significant refractive shift. And so if you're only looking at numbers, pardon me, to me this looks like a normal cataract patient who's got some astigmatism, and maybe we can do just plain old cataract surgery or perhaps do a toric IOL. Who in the audience uses the Pentacam for their calculations or for looking at the cornea? Okay, so if I didn't show you anything and you saw these numbers, who in the room would say maybe this is a toric IOL candidate, maybe even a multifocal toric candidate? Yeah, right now. There's no tricks here. No tricks. Yeah, why not? Audience, panel? It's a little weird. It's a weird axis, but we're just looking at numbers. Now, I do have a Pentacam AXL sitting right next to an IOL Master 700, and we were sort of comparing and contrasting the two. But here is his biometry on the IOL Master 700, and it does confirm that there's a fair amount of astigmatism in a similar axis to where his glasses are. If I only show you this, has anyone's mind changed? Now, I'm going to play a little bit of what WWHD, which in my book is what would Dr. Holladay do. So I try and channel Dr. Holladay's skills in looking at biometry and play some games here. So Dr. Holladay, what would you, just looking at this, I know there's more data we're going to want to see, but is anybody wanting to change their plan, or are we still doing a toric IOL?
Well, the first thing I noticed is that the astigmatism, that delta D was 345 and one's 275, and on the manifest and on the other it was about a diopter less in both eyes, both on his manifest and the old glasses. So I would be, well, I don't trust those delta D values right now because I know they just reflect front surface.
So things are not adding up. Glasses are one thing. What we're seeing on our biometry is another. So what would you do? We've already gone over this. And now we look at our Pentacam. Again, this is just a guy that picked me out of the phone book to come in for his cataract surgery. What are we seeing here, guys?
Tom, you guys?
Again, this is not a trick.
On anything? What do you see there?
Keratoconus.
Exactly. He's got a couple of things, but as we mentioned, in that upper middle panel, you notice that the displacement of the thinnest zone is 0.72, and I said 0.61. You notice that the elevation is red. I mean, that's as classic as keratoconus as you can get. But also you see two other things. You see that on the tangential and on the axial power map, that there's broken semi-meridians, and even on the steep axis, it's not aligned, so you know that astigmatism is not trusted. So even though the EKR 65 measures 0.95 there, diopters of astigmatism, you know that's all over the place. And the other thing that it points out is that the value is 1.7. So this guy's quality of vision is going to be terrible because it's much greater than 1 micron. And the other thing is chord mu is very large. And chord mu gets distorted in a cone because it moves over the light reflex further from the center of the pupil. So basically what I would say is that the guy's got irregular astigmatism. I don't trust the axis of astigmatism, and I wouldn't consider a multifocal lens.
Okay.
And top of this, maybe you can go back. If you have these cones, I mean, there's always the question is, You correct them with toric lenses, for example. We wouldn't do multifocal lenses with it because there's no indication you have a steep cornea below, you have a flat cornea in the upper part. So you correct astigmatism, but still, if you would correct with a toric lens, then you still have the problem that the cornea changes, maybe over time. So in our opinion, here is a good indication for first doing cross-linking on the cornea and then wait till you have a really good outcome or really stable cornea and then go in toric lenses. Still, with toric lenses, you still have irregular, as Jack pointed out, you still have irregular because the intraocular lens cannot correct the whole astigmatism at here because we have not a customized toric lens. We still have one axis.
We could probably take this scan and talk about it for an hour by itself as far as, do you cross-link this patient first and then do you have to wait a year? But look, he's had a 3-diopter myopic shift. Is this guy going to wait a year for cataract surgery? He's 70 years old. What are his risks of, there's lots of issues.
Yes, especially when you say he's 70 years old and just the last 2 years, suddenly his cornea has changed. Yeah, if we talk about a keratoconus patient who was 70 years more or less quiet, and then suddenly it changes, it should also tell us something.
Or is he getting his myopic shift from his lenticular changes?
Yeah, not necessarily. We don't really know. I mean, part of it. Yeah.
So, no matter what I do, I can't escape keratoconus. I guess it's just what comes into our office. But our plan is, now my thought process, and you can tell me if I'm an idiot, that's okay, was to plan for cataract surgery, and his objective was to try and minimize his dependence on glasses. He said, man, Doc, it'd be really great if I could get out of these glasses. I've been wearing them forever. I looked at his Holladay report and kind of said, maybe, but he does do pretty well with manifest refraction. I can get him down to 20/25 with glasses, and admittedly, he says, I've had astigmatism for years and years, and so what do you do? So what power IOL are you going to place? We've got this crazy looking cornea. And if you're going to do a toric IOL, what axis are you going to put that at? So I'm going to bring back his Pentacam, the Pentacam image again. And how do we use this to decide, and I'll show you the next page too, how do we decide what our axis is, what power we're going to use, what T power we're going to use? Because as that pupil dilates, we're going to move into more and more zones of astigmatic correction. And if the patient says to me, I wouldn't mind not needing to wear glasses for near as well, in a cornea like this, do we need to do a multifocal lens? Now, honestly, I would never put a multifocal in a cornea like this, but does he need a multifocal to have at least bifocal vision?
Well, there's 3 things I would point out. First of all, at 1.7, a multifocal lens in this guy would be contraindicated in my mind, simply because he's already got glaring halos and it'll make it worse. Now, the second thing, if you look across from the 1 up to the 7 millimeters at the astigmatism, he goes from 0.39 to 5.8 and maximizes at 4.5 at 0.94 and actually goes down a little bit over that. Now, that's only because when you look at that island within that red 4.5 millimeter zone, it's real irregular. You're not going to get a good, but the flat meridian is, and we look at the axes for that, and you see that axis 74, 69, 65, 62, and then I look at the steep. What I'm saying is I think somewhere around 65 degrees is with 1 diopter, which means you'd use that T2, or 3, the 1.5 diopter. I think you could get away with using a 1.5 diopter toric lens and use the power. The other thing you see is the EKR global is 46.18 or 6. And the EKR 65 is 45.3, almost 1 to 1.25 diopters flatter. And so again, that flatter power, he's not looking through that peak on the right down in that lower left, and that peak is the cone coming into the zone. So I would say that using the 45 diopter power is pretty good, and using 1 diopter of corneal astigmatism would give him a fairly good result.
Now, the one thing I want to point out in these scans is, and this was true clinically as well, look how small his pupil is.
Yeah.
You see that tracing. This guy has a very small resting pupil. And so I took that into consideration as well when I was looking at these scans. And so when I did a couple of of measurements. I just used my IOL master data, which was calling for somewhere around a T8 or a T9, which was a much higher toric power than what we were just talking about. And when I put in the Holladay report data, it was asking for a much lower toric power. But I wasn't really comfortable because the fellow was refracting with about 2.5 diopters. So I still had a high and a low. And so let me see. No, I don't want to go that fast. Sorry. That was the better lucky than good slide right there. So what I did is I was trying to channel, the refractive data in this from Dr. Holladay. I looked at that very small pupil and looked in that zone. And in that small pupil, he actually has if you subtract everything else out, he's got about 2 to 2.5 diopters of SIL in that little tiny pupil. And so I went to the OR with both. Now I never trust that T9. That he doesn't need that much cylinder correction. But I went with a T3 and I went with a T6 into the operating room. And I am able to cheat because we use intraoperative aberrometry, but admittedly with a keratoconus cornea, you can be thrown off with intraoperative aberrometry as well. And so when I looked at that small central pupil and kind of calculated about how much cylinder was in there, I went in with the T6. We ended up placing the T6 and he is uncorrected 20/25. So I think in this case, it was much more lucky than good. But being able to have all that data without having to flip through 5, 6, 7 pieces or 7 sheets of information in front of me, we were able to come up with some kind of a calculation to get this guy out of glasses. And interestingly, when I looked at that second page of the EKR data, this one here, this fella does actually have much better than expected near vision given his good uncorrected distance vision. And that's probably because he's got that crazy shaped keratoconus cornea. So that's better lucky than good. Let's move on here. So second case. Case referred into me, a 68-year-old woman with the dreaded RK. RK, in my opinion, is a bunch of bad decisions now in the past. She's now already had a corneal transplant in the left eye because of the RK, leaving her with irregular astigmatism. And now she's developing a cataract in the right. We really don't want to have to do a transplant on the other eye, and I don't think that we're going to need to. In fact, she had cataract surgery in the other eye prior to her transplant, and so her case completely changed after her transplant, so she had to have an IOL exchange in the other eye. So this lady's already coming in frustrated. My one eye's now taking me 2, 3 surgeries to get to be able to see. Let's get this one right this time, doc. So now I'm on the hot seat trying to make sure we're going to do the right thing for her. So vision without correction, 20/50 on the right side, 20/30 on the left. Again, the left eye has already had multiple surgeries. Refraction, not surprising. She's a little bit hyperopic with cylinder on the on the right eye. Close to plano on the left. That's actually an amazing refraction given she's had a corneal transplant. I believe she did have a toric lens placed on the left side. Manifest doesn't change that much. We can get her down to about 20/30 vision. This is the picture of just a placido disc base. This is the OPD scan, just your regular quick and dirty topography confirming that flat cornea, and that's a picture of her with a little bit of subepithelial fibrosis as well as the RK incisions. Again, 8 little bad decisions all in the cornea. And here is her Holladay report. Again, a lot of information all at once here. The topography, the tangential and axial reports show a fair amount of irregularity, guys. Would you agree with that?
Yeah, what's the value there? I can't read it. 1 point, what is the RMS there?
Oh, the RMS is, I think it's like off the
Scale,
off the chart.
Yeah. But I will tell you that she does have 1.5 diopters of astigmatism, and the axis that she has there was close to that 45 degrees. So I think that's pretty good match to what she's been walking in with her glasses and stuff. And the other thing that you see there is her spherical aberration is off the chart too with a positive value. So she would be a good candidate for an aspheric lens as high as you can get. And you could probably use a toric lens that would match that 1.5 diopters of astigmatism. So it'd be about a T4.
Okay, let me just show you the rest of her report, because this is a pretty classic example of that arcade. And you brought up how spread out that refractive data is over the cornea. You can see that flattening of the cornea. So clearly this is not a normal case. Does anything else jump out at you here? And I'll warn you in advance, I chickened out on this case. I just wanted to get her close to Plano. In my mind, I didn't trust my topographies, I didn't trust her refractions, so I did not plan on a toric in this case. Maybe I should have.
Well, and the other thing that you see is that 3474 is what that EKR mean, and the global is 3494. And it's amazing in that RK patient, and you can see that on the right on that flat mark, but although she has a kind of a dome-shaped power, it's actually fairly flat over that center zone and 35. So I think what'll happen is that 35 diopters of power for that K reading is going to be pretty close to a calculation that'll get her to hematropia.
Still.
So we ended up using that data for a post-refractive calculation, confirmed that with Aura, ended up placing a wavefront lens, 25 diopters, ending up with no toric in this case, ending up with 20/30 uncorrected vision. And admittedly, I probably should have put the toric in because she does do a bit better with just a touch of refraction.
What was her refraction?
She's a diopter,
Huh?
a diopter still.
Yeah.
In the same axis. So I missed on this one. I should have trusted the data, but I didn't. But honestly, in my book, with her story, I'm okay 20/30 uncorrected. Yeah, I'm okay with that.
One thing you could consider is using like a small aperture IOL in a case like this, like the IC8. I don't know if it's available in the US. No, it's not. But I
Yep,
think,
nope, can't do that.
yeah, but this would very elegantly solve a problem.
Well, we've been really looking for and hoping for small aperture IOLs for a while, but so far in the States, we don't have access.
Okay.
Yeah, I would agree with Gerd. We would go now more for these lenses because you can do whatever you want. You take your non-toric lens or you take a toric lens, you always come under the question, what should I correct? With these small aperture lenses, you can even, consider 1 diopter, 1.5 diopters.
So you can
astigmatism.
ignore
You don't
that
have
cylinder.
to do astigmatic corrections because you basically, you get this small aperture. These become to be very popular for RK patients because you basically turn down and you concentrate everything on the center of the cornea, which usually doesn't have the RK cuts. In the center, it's okay. So therefore, we're moving in these directions. We have the same problem with these lenses, but I agree with Gerd. We're moving in this small aperture.
So we still have, I do, probably an RK patient a week, and they're sent because we have all kinds of biometry and we use intraoperative aberrometry, which in my case has been quite helpful at confirming some of our biometry in the OR. But having a small aperture IOL would be fantastic because I think we could get away with a lot more with these patients.
An alternative to these complex cases, also the previous one you had, is the use of supplementary lenses that you put on a basic monofocal lens, then in the sulcus. So-called add-on lenses. So what you do is you would do the surgery, you would wait like 2 months or something until everything has settled down, and then the residual error, then you can very accurately correct with a toric, in this case, or in the other case, toric
So
supplement.
with a toric piggyback IOL.
Yes.
So put your primary lens in, wait for things to settle down. Now you know your power of the IOL. You've figured out your power of the cornea.
You just
and
need the subjective refraction for calculating the piggyback lens in this case.
So we still in the States, unfortunately, we don't have a sulcus-based toric that we can use.
Right, and that's the problem, that the diameter of that in the sulcus, you could use a toric lens, but the problem is that they're not big enough in diameter to be stable in the sulcus, so you have to suture it or something to get it there. That's exactly right. We don't have that. Now, the other thing is that IC8 is something that is in clinical trials right now, and within a year, we hope to have that in the United States. And here's the thing that people don't realize about that. And that not only eliminates astigmatism and helps you with depth of field, so it helps even get rid of sphere, but the benefit in the higher order aberrations like this are even greater because it's exponential. In other words, it gets rid of 6, 7, and 8 higher order aberrations 10 times more effectively than it does sphere and cylinder, and the result is that these patients get rid of halos and glare. And so once again, when you're over 1.0 or 1.5 in your in basically the RMS error, you're going to have a tremendous benefit because these patients will love you because not only they get a little near vision intermediate vision, they also eliminate their halos and glare. So that'll be something that this year will work out well.
All right, so I am done channeling the WWHD here. Any questions for me on our cases or any other discussion points? All right, then I think Dr. Holladay's coming back.
Okay, that's good.